Assalamu alaikum. So today we have an interesting case of regenerative endodontic treatment for mandibular second molar with both C-shape anatomy and also torturism. And this case was published by one of our graduates, which is Dr. Ali Addokhi with Dr. Abuhaimed. It was published in the Saudi Endodontic Journal in 2026. So the case presented of 12 years old healthy female patient who presented with subcutaneous pain in the lower left posterior region that was not relieved by painkiller, and the patient guardian reported that the patient received initial root canal treatment for this tooth. However, the pain still persists. In clinical examination, tooth number 18 has a temporary restoration, was not responsive to the cold test, and was tended to percussion and palpation. And periapical radiograph demonstrated incomplete root canal development with apical radiolucency. CBCT scan confirmed the mesiotorturism for this tooth and also class 2 C-shaped canal configuration with immature roots. And based on these findings, the diagnosis was previously initiated root canal treatment with symptomatic apical periodontitis. So after discussing the available treatment for the guardian of the patient, which was including traditional epoxification with an MTA and also regenerative endodontic treatment. And the clinician in this case preferred regenerative endodontic because of the patient's young age, immature root, and also the potential for continued root development with the regenerative treatments. So the treatment was completed over 2 visits following the guideline of the European Society of Odontology. In the first visit, the tooth was isolated with the with the rubber dam, and the canal was irrigated with 1.5 sodium hypochlorite followed by saline. Also, calcium hydroxide was placed as intercanal medicament, and the tooth was sealed with cavities. 2 weeks later, at the second visit, when the patient was asymptomatic, the canal was irrigated with EDTA to promote stem cell attachment and release of a growth factor for the dentine, and the bleeding was induced beyond the apex to create a blood clot scaffold, and also a collagen plug or collagen matrix was placed over the blood clot. That was followed by an MTA placement and a GIC liner, and finally with a final restorative material, which is composite. At 7-week follow-up, radiograph showed a reduction in the periapical radiolucency, and the patient remained asymptomatic. At the 6-month radiographical examination demonstrated resolution of the periapical lesion, continued root development, also an increase in the canal wall thickness, and evidence of apical closure. And the CBCT also confirmed a complete healing and formation of irregular mineralized barrier. At 1-year follow-up, the tooth remained asymptomatic with no tenderness to percussion or palpation, although cold and electrical pulp tests remained negative. However, the radiograph and the CBCT demonstrated a complete apical closure, classification within the canal, and also complete healing of the periapical tissue without any sign of a treatment failure. The author discussed that the regenerative endodontic treatment was preferred over epoxification, as it will provide the possibility of an increasing dentinal wall thickness and also continuity of the root development. Also, they emphasize that there are 3 factors for the success of the regenerative treatment, which is effective canal disinfection, appropriate scaffold to support the tissue regeneration, and also well-sealed coronal restoration. And thank you.